Are we recording? Guess there's sort of a delay. So for those of you who do not know me, have not attended before, I'm Rhea Markowitz from the Georgia Cancer Center, and I'm part of the hub team of our TeleDerm project. Brenda Santiano and I will be serving as co-facilitators of the session today. Dr. Patton, who usually co-facilitates with me, is not able to be here today. So I want to thank all of you for being here, and I ask you to put your devices on gallery view so we can see each other when we're not sharing the screen. And I want to welcome everyone. Some of you I see are from our previous clinical project that was supported by the USDA, and that includes healthcare providers from various healthcare clinics throughout the state of Georgia. So we welcome you back. We may have some residents and faculty, I saw we did, from the Phoebe Family Medicine residency program in Southwest Georgia. And I think we have residents and faculty from the Family and Community Medicine residency program here at MCG. And then, of course, we have faculty and residents from the MCG Department of Dermatology, including Dr. Loretta Davis, who will be presenting today, Dr. Harold Rabinovitz. I don't think Dr. Kendall Buchanan is on today. Dr. Buchanan, who was presented a lot in the past, she's on maternity leave, and we congratulate her on the birth of her son, Riley, in early December. She'll be back in a couple of months, I think. We may have members of the Dermatology Nurses Association. We have some MCG medical students, Mackenzie and Gabby, who've been with us before, and maybe some new medical students, including one of our case presenter. And hopefully we have some of our participants from around the globe, as we've had in the past. And then anyone who is attending for the first time, I welcome you and hope you will come back. So one of the things we do is put into the chat the your name, your full name, your email address, and your affiliation, the clinic or program that you are with. And I believe there's an example in the chat. I'm not using my laptop today because of some issues, but please remember to put that information in the chat as we move along. And so here is the agenda for today. As usual, we start with some introduction, which we've been having. We will have a didactic presentation by Dr. Loretta Davis, who is a professor and chair of the Department of Dermatology here at Medical College of Georgia at Augusta University. And then we'll have a case presentation by Edwene Coulange, and I hope I said that right, a third-year medical student here at MCG, and we'll have questions and discussion, and then we'll have a wrap-up and announcements. So we'll start with some of our TeleECHO announcements. So this is our session is part of Project ECHO, which is the extension for community healthcare outcomes, and with the philosophy of moving knowledge instead of moving people. So we do it by Zoom, and always have been doing it by Zoom pre-pandemic. So our goal is to improve knowledge by telemedicine, in our case, teledermoscopy and teledermatology at the local level, and to use distance learning approaches to help solve the dermatologic health disparities faced by people living in rural areas of Georgia. And as required by Project ECHO, all TeleECHO sessions are recorded. And by participating in the session, you're consenting to be recorded. Please, in our discussions to protect patient privacy, do not mention any PHI in the discussions. And at the very end, on the slide, we will have the information, the code number for getting CME or CNE. And if you have any questions, please let us know at email us at teledermatology@augusta.edu. And just notification, the Project ECHO collects your information, where you are, who you are, and that data is kept confidential and is just used for reports and mapping and communication purposes. General Zoom reminders, keep yourself muted when you're not speaking. And then when you do speak, remember to unmute yourself. If you have questions throughout, you can type them into the chat. We monitor that. Raise your electronic hand, raise your biological hand, speak up. And when you do speak, if you can introduce yourself by name and what your affiliation is. Please keep your camera on as much as possible and use gallery view. And if you have any technical issues, you can use the chat, although if you have technical issues, you probably can't get in the chat, but email kenza@kmamuni@augusta.edu. And you know what I think that as I was introducing everyone, I totally forgot to mention your team members in the hub here, who keep all of this in working order. So Kenza Mamuni, Brenda Santiano, and then there's me, but I introduced myself already. Okay, so let's get on with the show. And I am happy to introduce our speaker for today. Dr. Loretta Davis is the professor and chair of the Department of Dermatology at MCG. She has been involved in our TeleDerm project and in our TeleECHO sessions from the very beginning. And she will talk about the Morbilliform rash today. So take it away. Can you go into, oh yeah, you're in presentation mode.
Am I in presentation mode?
Are you?
Not really.
Now, we're seeing
The next
slide here. Can you?
Am I the one in charge here now?
Yes, you're in charge.
Okay. Okay. Perfect. Thank you so much.
In
Well, I decided we would talk about red rashes, and that is a lot of dermatology. It's very confusing. Lots of things on the skin are red, and generically they're called the rash. And so I thought we would just talk about very specific morphology, the Morbilliform rash. So we're going to do that for the next 20 minutes, and I hope that we'll be diving down into this, and it'll all be very clear when I get done. So we use a lot of synonyms in dermatology. So morbilliform is the same thing as maculopapular. Okay, so we use those interchangeably, which can be very confusing. And so to be a maculopapular or morbilliform rash, you can be a macule, meaning you can be a pink flat spot that's less than 1 centimeter, or you can be a papule, which is a raised pink spot less than 1 centimeter, or you can do both. You can have both. And that can be confusing. But anyway, that's how we make, if you have this morphology, then you fall into this morbilliform skin eruption. And it can become confluent. So those papules or those macules can all kind of grow into one and be big patches or plaques as well. And sometimes it's a little tricky to figure out what done it. Even more confusing is that we have more synonyms. So morbilliform or maculopapular means measles-like. Okay, so it looks like measles. If it's all papular, sometimes we say it looks like scarlet fever, scarlatiniform. If it's all macular, some people use the term toxic erythema. And if it all comes together, we throw in erythroderma, and that's when you really don't want to be a dermatologist or listening to me. So it can be very confusing. So we tend to use the term morbilliform or maculopapular primarily. What's really important with morbilliform eruptions is that the lesions are fixed, okay? They don't move around. And that's in contrast to urticaria. So in urticaria or hives, the lesion, an individual lesion lasts less than 24 hours. It's evanescent. It doesn't last very long. So if you're not sure, what we do is sometimes we'll circle a few spots and we'll tell the patient to let us know if the rash is still in the circles 24 hours from now. Or if we're in the hospital setting, we might circle some spots and go back and look at them in 24 hours. And if it's a morbilliform eruption, the spots are still going to be there. In hives, they will have moved on someplace else. So hives are transient. In morbilliform eruptions, they are fixed. So that's a good trick. And the other thing is that there is no scale in a morbilliform eruption. Okay, so these are not scaly. These are red, flat, or raised lesions. So what triggers a morbilliform eruption? It's pretty simple. I mean, it's either virus or drug, or drug in the setting of virus. Okay, so if it's a true morbilliform eruption, we're talking about virus and or drug. So here we have two patients with morbilliform eruptions, okay? And I can't tell you whether that's a drug or a virus by looking at this. So sometimes you need to have extra clues. So one extra clue is if it's a child, it's usually a viral exanthem. So probably 80% of the time, if a child, a 7-year-old shows up like this, it's going to be virus, 70 to 80% of the time. That means, they could be a drug that triggered it, but you're going to kind of play the odds. If it's a young person, you're going to think more viral exanthem. If it's an older person, an 80-year-old, you're going to think more drug eruption. So age makes a difference. So 80% of people in adulthood who come up in with this, it's going to be a drug induced. Now, what else are clues? Well, if someone comes in and they have cough, fever, nausea, vomiting, diarrhea, headache, myalgias, they probably are sick and they have a virus. And so that is very helpful as well. If in drug eruptions that are truly morbilliform, people are not sick. This does not make them sick. They might be a little itchy, but they don't have these symptoms. And in drug-induced rashes, morbilliform rashes, sometimes the rash looks a little bit odd. Sometimes it looks a little bit more like a hive urticaria, like I mentioned, but it doesn't float away like urticaria. Sometimes it has two zones of color. It's a little lighter in the middle, a little like a target, but not really like a target. So it just looks a little meaner, okay? A little bit meaner. And sometimes that's helpful in making a diagnosis. Now, what happens if it's a virus? Well, any virus can cause a morbilliform a morbilliform reaction. Exanthem is the term we use. It can be EBV, like in mono. It can be an enterovirus, like rhinovirus. These common causes of the common cold, adenoviruses, HHV6, which causes pityriasis rosea. And then I will say the one thing I would be worried about is if I had an adult who came in with this, who did IV drugs or had promiscuous behavior and unprotected relationships, then I'm not worried about acute HIV because that is a virus. So acute HIV, an acute infection of HIV can present with a morbilliform viral exanthem. Another clue can be eosinophils. So we don't usually draw labs on people who come in with these reactions, but if we did, or if we were worried, you might see a peripheral eosinophilia if it's a drug that we wouldn't expect if it were a virus. So sometimes that's helpful. We don't usually do skin biopsies because they're non-specific, so they're not particularly helpful. But if you had a challenging case or you did one, you'd be looking for eosinophils in a drug eruption, which you wouldn't expect in a viral exanthem. But they're not always there, even in a drug eruption. 30% of the time, you're not going to even find eosinophils. So it can be a clue, but we usually don't go down that route. The big thing is that, with a viral exanthem, usually people feel sick. With morbilliform drug reactions, which is the most common type of drug reaction, okay, people do not feel sick. They might be a little itchy, but they come in like this. They've got their pants and their belt on. They're going to work and they just don't look so good. And they might look a little scary, but it's not, they don't feel ill. So now, if you've decided maybe it's a drug reaction, what do we think about? Well, usually these spots, as I said, they're always macules and papules, and they're blanchable. So if you take your thumb and you push on them, the redness goes away, and then it's flesh colored underneath. Okay. It's fixed. They don't move around. And then the differential is a virus. We don't fully understand the pathogenesis of these things. They're probably T-cell mediated immune reactions, but it's kind of complicated. But the bottom line is people do not die of a morbilliform drug eruption, and almost any drug can do it. And we are in a society where lots of people are taking lots of medicines, either prescription over the counter. So we see a lot of these. They usually happen less than a week after starting the medicine, but they last 1 to 2 weeks. So they go on for a while. There are lots of interesting things about morbilliform reactions. One, you can get it after you stop the drug. So maybe you take an antibiotic for a week, and on day 8, all of a sudden you get a rash, or day 9, that can still be due to that drug. And sometimes even if you stay on the drug, the rash will go away. And sometimes that's important because we can't stop every medicine. So they can go away even if you're still on the drug. And the next time you take that drug, you might not even get that rash when you're rechallenged. And it's probably because if you take a drug and what you really have is a virus, you're much more likely to get a rash. Okay. So again, a medication, an antibiotic in the setting of a virus instead of a bacterial infection, you're much more likely to get a rash. And that's the whole story with mononucleosis. If you have mono and EBV infection, and then someone gives you amoxicillin, which you didn't need, then you're more likely to get a rash. And that's the reason HIV patients get many more drug rashes, because they have chronic viral infection, and a chronic viral infection is going to predispose you to getting drug rashes. And the most common drug rash is a morbilliform measles-like drug rash. We see them all the time. So identifying the culprit drug, you got to do a good history, and you've got to include over-the-counter medicines. A lot of people do not know what they're taking. Sometimes we go to the EMR and we look at the recently filled drugs, because I've had patients tell me, I'm not taking anything new. Nope, nope, nope. And then you look and they just finished an antibiotic for their UTI. So you really kind of dig deep sometimes. You study the timing. So you're looking for something that was started, a week ago. And patients are, they're challenging. You prescribed something 3 months ago and they really never took it. And now they have their appointment with you. So they start taking it a week before the appointment, and then boom, they get the rash. So we see, those types of things. And then we check for the major offenders. So even though almost any drug can do this, some of them are really guilty parties. And so many people take so many drugs. Digging through this is a bit challenging, especially in the inpatient setting where you got to be a little bit more like Sherlock Holmes, because people are on so many different medications in the hospital, and they may have been on 5 different antibiotics in the last week. And that's when you have to do a little bit more sleuthing. So we have common offenders for morbilliform drug eruptions. Penicillin family of drugs, sulfa family of antibiotics is big time. Cephalosporins can do it. Seizure medicines are big time. Allopurinol is big time. And then the HIV medicines, abacavir and nevirapine, they can do it as well. But there are some big offenders on this list. And in my book, sulfa antibiotics and seizure medicines and allopurinol are the worst actors. So, of course, we're going to try to stop the medication if we can. But I tell my patients, especially my inpatient teams, if I see a consult, I may stop your medicine, but the rash is going to run its course. Okay, I can blow out the match. I can stop the medication, but the fire has already been lit. I cannot stop the fire if I'm just blowing out the match. Same thing with the horse. Closing the doors, does that going to get that horse back in there? The horse is out of the barn. So it really saves you a lot of aggravation as a provider. If you tell people, I'm going to recommend we stop this, but the rash is going to get worse before it gets better. Okay. And I think that's really helpful if you don't want to get called on the weekend when things are getting worse. So we're going to educate people. We're going to tell you that this rash is going to get worse for at least 1 to 3 days, even if I blow out the match and stop the medicine. Usually these rashes start on the trunk and they work outward distally to the extremities. And it's going to take 1 to 2 weeks to go away, even if I stop the medicine. So you're not going to get better overnight. And that education is really helpful because otherwise people are calling you and annoyed and it's getting worse. And you want their family members to know it too. You're going to try to avoid that drug in the future. But if you're in the hospital and people need their antibiotic and they've already been switched to a bunch of different antibiotics, sometimes we might discontinue it because we don't have a good alternative. And again, it's because if it's truly a morbilliform eruption, it's uncomfortable, but people do not die from these things. And then, we're going to do supportive care for itching. Sometimes we use lotions with menthol and camphor because it feels cold and it feels good. It covers up that itch. We'll use topical corticosteroids. Sometimes, quite honestly, the rashes are quite, often involve a lot of large body surface area, and it's not fun to put those on, but some people may benefit from that. And we don't use prednisone because it's never been shown to help or to shorten these reactions. Okay, so now what do you do if someone comes in with a morbilliform eruption, but it's a month later? Okay. Remember, I told you morbilliform eruptions are supposed to happen in the first 1 week or so, 2 weeks at the most. But what happens when it happens after that 2-week mark or up to 6 weeks later? Okay, after the drug that you think did it. Should you be worried? You think? You think so? Yeah, I'd be worried. I'd be worried because when you get that scenario of a late morbilliform maculopapular drug rash, you're going to be thinking about DRESS syndrome. Okay. DRESS stands for drug rash with eosinophilia and systemic symptoms. This name has changed 4 or 5 times since I've been practicing. It'll drive you crazy when they change names. We used to call it drug hypersensitivity syndrome. It's evolved, but it's all basically the same thing, which we now call DRESS. Okay, so drug rash with eosinophilia and systemic symptoms, or DRESS. As I said, some people call it hypersensitivity syndrome from drug rash, but it can be life-threatening, and that's why it's important to recognize 2 to 10% of the time. So it's a multi-organ problem. We don't fully understand the pathogenesis, but people who get this probably don't metabolize their drugs like the average person. There's obviously some immunology involved because you probably have to be sensitized. We can do skin testing afterwards to try to figure out which drug did it. And if you re-challenge the patient the next time, which I don't recommend doing, the rash is going to come back much faster. We know that some people are genetically predisposed, so there's certain HLA alleles. So with abacavir, they actually recommend pre-treatment genetic testing so that you don't give it to people who have certain HLA alleles because they're much more likely to get DRESS. And we're finding out more and more there's virus reactivation in a lot of these individuals. And remember when I told you virus plus drug is bad. So we know there's something going on here, even though we don't traditionally test for it. Some places are beginning to. But suffice it to say, this is when you see this macules and papules, and they're spreading, but it's way later than it should be. What's different about it, too, is it starts as morbilliform eruption, macules and papules, but next thing you know, the patients are getting edema of their skin. They get this characteristic facial edema, and then they get some purpura, and that's not what you see in a morbilliform eruption. So most of these people are going to end up in the hospital if they're not in there already. They have fever, they have lymphadenopathy, they get peripheral eosinophilia, they atypical lymphocytes, they get transaminitis. And so, the ALT can be as much as 2 times higher than normal when you're making the diagnosis, but 50% of the time it's over 10 times higher than normal. And so that can be, again, life-threatening. You can get itis of any organ you own. So you get nephritis, myocarditis, pneumonitis, myositis, thyroiditis. So you're going to start off with your CBC and your CMP, but you're also going to do a chest x-ray if you have symptoms of shortness of breath, or if you're having skipped beats, you're going to maybe get an EKG. You're going to stop the culprit drug yesterday. I mean, you really want to get these people off this medicine. And I hate steroids, but this is one of the time where you're probably going to have to use systemic steroids for a long time with a slow taper because it can recur. If it's mild, meaning people have a rash and minimal liver enzyme elevation, you can treat them topically, which might be wise if they're brittle diabetics. So you just have to follow these people and follow their symptoms. But the bottom line is, unlike a true morbilliform eruption, people with DRESS look and feel sick. Okay. You look at this child and he does not look well. You see the positive hospital sign, hospital bed, and you see this telltale facial swelling. Facial edema is really pathognomonic of DRESS. You'll see that. You get a little mucosal involvement, but it's not really very, significant for most people. And then these macules and papules become purpuric, meaning you push your thumb on them and the color does not go away because now there's some blood in the tissue. So it gets more purple. Okay. In addition, again, not only do they look sick, they have fever. You can feel, and you should do a lymph node exam because you're going to be looking for lymph nodes in more than one area, usually 2 or more areas to make this diagnosis. And they have to be bigger than a centimeter. And then you're going to see abnormal labs. And this is another one of my patients. You can see she's got some desquamation. So even though morbilliform eruptions don't usually do that, unless they're healing, 2 weeks out, they might scale a little bit. Okay, but you can see she's got some exfoliative dermatitis, which can happen. You see that telltale facial edema. This is not good. And then you can see where some of her spots are becoming more purple. And if you push on them, they don't blanch. So again, this would be very common in DRESS. The list of offending drugs are all the same bad actors, okay? So again, any drug can do these things, but we used to call this dilantin hypersensitivity syndrome because dilantin was the first drug that was shown to do this. And then they showed that phenobarb can do it too because there's a lot of cross-reactivity in the seizure world. And so they call it anticonvulsant hypersensitivity syndrome. And then sulfa antibiotics, they got in there because they always get in there. So then they just called it drug hypersensitivity syndrome. So again, if I'm looking at a patient list and I see a seizure drug, a sulfa antibiotic, or allopurinol, those are bad drugs. You'd have to pry my mouth open to take some of these drugs just because I've seen so many bad drug reactions with them. Sometimes this is a hard diagnosis to make. So there are actually two different suggested ways of making the diagnosis. There's a Japanese system. We usually use this British system, European system called the Registrar, where you get points for different kinds of positive findings. So you get, if they have high fever, if they have lymph nodes, it's yes or no. Atypical lymphocytes, yes or no. High eosinophils or super high eosinophils, greater than 50% rash on the skin. Or if you have a lot of edema and purpura, you get different points. If you have one organ, which is usually the liver, you get a point. But if you have 2 or more organs, then you get 2 points. And then you also have to prove that it's not lupus or sepsis. So viral hepatitis. So you do those kinds of things. And so basically, if you have less than 2 points, you don't even have a case for DRESS. If you have more than 5 points, then it's definitely DRESS. And then if it's in between, then you have to scratch your head a little bit more. But I think that just helps with management because you don't want to overtreat people and jump in with high dose systemic steroids unless you need to. But this is what we use when we see hospital consults. And the question is, does this patient have DRESS? Okay. So again, we're going to stop the culprit drug. We're going to give systemic steroids and we're going to give high doses and we're going to wait till that patient's getting better. And then we're going to slowly taper so it doesn't recur. We are going to sometimes use topical steroids if it's not so bad. And we're going to really, tell these patients to go get one of those wrist bracelets that tells them not to do this again. Don't take this medicine again. Okay, so, I like to end my things with a little quiz. So if you have a patient with a severe drug reaction to TMP sulfa, okay, should their daughter be worried about taking this drug? What do you think? Anyone? If my mom had one of these awful drug reactions to TMP sulfa. Should I be nervous about taking this drug? And I would say yes, true. And a lot of these, especially with sulfa antibiotics, a lot of these allergies seem to run in families. So I don't prescribe anticonvulsants, and I don't prescribe allopurinol, but sometimes I prescribe sulfa antibiotics for bad staph infections, and we used to use it for bad acne sometimes, and occasionally we do. But I always ask the question, I mean, does anyone in your family have a bad allergy reaction to sulfa antibiotics? And if I get the answer yes, then I try to go down a different path, because I think the odds of those people getting a drug rash is pretty darn high. I'm allergic to sulfa. I found out from my mother when I was a child, and my sister is, my nephew is, my niece is. I've never given it to my own kids because the odds are they might. So I think that's really important. I hope that sometime before I retire, they will be able to do a blood test, or something, so we will know whether we can give sulfa antibiotics to people, and especially seizure medicines to people, allopurinol, those types of drugs. It'd be nice to know whether we could avoid something like DRESS syndrome or Stevens-Johnson or TEN, which I will maybe talk about another time. So just remember, drugs are an invitation to trouble. This is a cologne that I saw advertised, and every time I see that cologne, I just somehow think about drugs and how they are the biggest invitation to trouble. And we prescribe them all the time. We just need to have a healthy respect for what they can do. So anyway, thank you for your attention. And I think we've discussed the morbilliform rash in enough detail to move on. Thanks.
Thank you, Dr. Davis. Thank you for your presentations. I don't know if anyone in the audience have any questions. You can type them in the chat or hide your hand. We are going to move forward, if there is no any questions, with our case presentation. A medical student, third-year medical student, Edwin Coulange, is going to present us like a series of cases that she prepared with supervision of Dr. Harold. Dr. Harold, thank you so much for helping us with this and helping us to prepare these cases for our audience here in teledermatology. So, Edwin, you can start. Just let us know when you want us to.
There is a question in the chat. I don't know if we want to address it first.
There is a question, Dr. Davis. Are there any helpful dermoscopy findings with morbilliform brushes?
Well, let's see, Dr. Rabinovitz may be a better qualified to answer that, but I think you're going to see erythema. You shouldn't see any purpura. You shouldn't see any scale. I would think that basically you're going to see a lot of redness. I don't know. Dr. Rabinovitz, do you have any suggestion, anything?
Other than see red areas or perhaps some telangiectasias, it's not particularly helpful, although you'll see from this case presentation that Edwin is going to present to you that dermatitis with dermoscopy do play an important role. So it's all yours, Edwin.
Well, thank you, Dr. Davis, for your wonderful presentation on morbilliform rashes. Good afternoon, everyone. My name is Edwin Coulange, and I'm a third-year medical student at the Medical College of Georgia. Thank you for allowing me to present this clinical presentation, and thank you, Dr. Rabinovitz, for your assistance in helping me put together this presentation. You can click. So in our case, we have a 62-year-old man with Fitzpatrick-6 skin, and he developed pruritic purple-brown papules and plaques for 3 months duration. There were no changes in his medications. He has no history of a viral illness prior to his skin eruption. You can click. So here we see higher magnification images. We're able to see the plaque and the papule. As I mentioned, these were very itchy and pruritic, which is suggestive of an inflammatory process. As the clinical pattern is nonspecific, a biopsy will be performed to hopefully make a definitive diagnosis. So the question is, can dermoscopy be of help? Click. So we're just going to review a bit about the dermatoscope. You can click. It's a handheld microscope that provides detailed visualization of the certain structures, including the epidermis, the dermal epidermal junction, and the papillary dermis. It helps us to visualize things that are not visible to the unaided eye, and it's a powerful tool that we've seen, especially in the past year and a half, to aid in the diagnosis of early melanomas and differentiate between benign and malignant, pigmented and non-pigmented lesions of the skin. Next. So normally, when light hits the skin, it's either scattered, reflected, or absorbed. One can't see the subsurface structures, but you can get better visual acuity of the lesion. Go ahead and click. 2 more times. So if we were to add alcohol or saline or oil, and then we place a hand microscope on the skin, click, we would then be able to see structures and patterns that aren't visible to the eye. For example, at the dermal epidermal junction, we'll see lines and holes. These correspond to melanocytes, and the holes correspond to the papilla. But if we go a little deeper, then we'll see round structures that are called globules, and they represent melanocytes in the papillary dermis. But if we go even deeper, we might see the vasculature, and different neoplasms have different vascular patterns. So focusing on clinical dermoscopy. We'll go to the next slide. At the Medical College of Georgia, we've been contacting a program called Teledermatology in rural Georgia. So the device that's used for this project is the dermatoscope. It allows us to focus on neoplasms in the skin, both benign and malignant. And it shows us, and another important role that we have for dermoscopy is inflammatory disorders. This is known as inflammoscopy. So these are images of the clinical lesions that I just showed you. You can go ahead and click. Here we see a central white area with intersecting lines. Go ahead. And then at the periphery, you'll see symmetrical peripheral gray rim. So to talk about the type of lesion, it's inflammatory. When we look at the characteristic features of these lesions, we'll see, again, the central white area with intersecting lines and the symmetrical peripheral gray rim. And then what are the colors that we see? We'll see dark brown, purple, blue, and white. Go ahead. So due to the pattern, we can tell that this is an inflammatory disorder. We can tell because of the central white area and the intersecting lines that this is suggestive of pigmented lichen planus. Go ahead. So what's our diagnosis? Here's the histology. You'll be able to see classic features of lichen planus. You go ahead and click. We'll have a band-like infiltrate, epidermal hyperplasia, and hypergranulosis as some of the key featuristics that we should look for in histology of lichen planus. Go ahead. So clinically, lichen planus will present as an inflammatory skin disorder, which will consist of pruritic, polygonal, purple flat top papules and plaques. But it can also involve the hair, the mucosa, and the nails. There are also a lot of medications that have been implicated in lichen planus. So these include things like thiazide diuretics, beta blockers, gold, anti-malarial drugs. We've even seen infections like HIV, hepatitis C, autoimmune disorders. And we've actually seen a couple of cases after vaccinations of flu or even COVID. So the etiology of this condition isn't really well understood, but it's possible that there's involvement of a T-cell immune-mediated response against basal keratinocytes. So here's another example showing you lichen planus. As you can see, again, dermoscopically, we'll have a network of intersecting lines, also called striae, and they'll also have dotted vessels at the periphery. Go ahead. This is a patient with Fitzpatrick foreskin. We can clearly see a central right area with intersecting lines. We'll see linear vessels that are surrounding the striae, we call them Wickham striae, and vessels at the periphery. Go ahead. This patient has Fitzpatrick 2 skin. Again, central white areas with intersecting lines, linear vessels surrounding the Wickham striae, and it's set on a purple to reddish background. And lastly, similar to the patient in our case, we have Fitzpatrick 6 skin. So with this, you need a vascular enhancer, and with the enhancer, you would then be able to visualize the linear vessels surrounding the Wickham striae. again, our widest structures. Go ahead. So the way features appear on dermoscopy really depends on the skin color. And these images allow us to appreciate how the same features can appear on different skin types, specifically Fitzpatrick 2, Fitzpatrick 4, and Fitzpatrick 6 skin. Go ahead. This is an example of lichen planus. It was treated with steroids and it ultimately resolved. Here, we're still able to see our Wickham striae and the vessels in the periphery. And over time, with the topical steroid ointment, it was able to resolve. Go ahead. So inflammoscopy is an extremely useful diagnostic tool, and we use it to evaluate rashes. When we're looking at rashes, we really want to focus on 3 features: vessel distribution, scale, and background color. So let's take a look at 3 conditions: psoriasis, dermatitis, and pityriasis rosea. Psoriasis is characterized by homogeneously distributed, small dotted vessels. In this image, these vessels will be the red dots. We'll also see a surface scale. Go ahead. Here we see vessel distribution, the scale, and the background color. You can click twice. Our vessel distribution is vessels as red dots. They're usually regular distributed. We'll have white scale, and then our background color is going to be light red. Go ahead. Here's another example. You'll be able to see the vessels as red dots, kind of over here. They're regularly distributed, white scale, and have a reddish background. Here we have psoriasis and lichen planus, and you can see dermoscopically the difference. So you'll have a central area, the widest structural Wickham striae surrounded by vessels, but as opposed to psoriasis, you'll have diffuse vessels as red dots. Go ahead. Next, we have pityriasis rosea. It's clinically characterized by a herald patch. Pink mapules and papules, usually distributed on truncal areas, and this is our corresponding dermoscopic image. Go ahead. So what do we see dermoscopically? You'll see a yellowish to red background, relatively homogeneous. We'll also see a collarette of scale and a few scattered linear or dotted vessels. Go ahead. Now, if we compare the two, in psoriasis, the vessels are regularly distributed, and with pityriasis rosea, they're scattered in just a few. In psoriasis, we'll have a white scale in comparison to pityriasis rosea that has a collarette of scale. And for psoriasis, we'll have a light red background versus pityriasis rosea that'll be yellowish to reddish. Go ahead. And then we have dermatitis. It can be coin-shaped, such as this image, which is known as nummular dermatitis. And these are classic dermoscopy features on the right. Go ahead. So what are the features that we're looking at? You can click twice. So we can see vessels as dots, but this has a patchy distribution. We'll also kind of see some yellow scleral crust throughout the image, and the background is a relatively pink-orange color. Go ahead. So now we'll compare the 4 conditions that we've just discussed. We'll have regularly distributed vessels as red dots with psoriasis, the white scale, the red background. In pityriasis rosea, we'll have dotted or linear, just a few, the collarette of scale, and the background will be yellow to red. In lichen planus, we have our dotted and linear vessels. They're scattered, but usually they surround Wickham striae, and they'll be set on a background of a purple to red color. And finally, with dermatitis, we have dotted vessels, but they have a patchy distribution. We'll have yellow scleral crust set on a light red background. Go ahead. So in summary, this case was presented to highlight the features of rash and skin of color. We also wanted to highlight the dermoscopic features of some common rashes. And finally, a question for the ECHO team. Based on this presentation, do you think that dermoscopy might help in the diagnosis of rashes? Thank you. And thank you again to Dr. Rabinovitz for helping me put together this presentation.
Thank you, Edwin. Thank you, Dr. Harold. Are there any questions from our providers?
And let's end the screen sharing.
Based on this presentation, do you think that dermoscopy might help in the diagnosis of rashes? Anyone wants to answer?
Any questions? Any answers? And are we screen sharing? Can we end the screen
Yes.
sharing?
Yes.
So I don't know if any or providers had a chance to saw any patient with rashes and you use the moloscopes or the dermoscopes with those patients. I'm pretty sure like down there in the clinics, you have a lot of patients. Dr. Martin Sheldon says, yes, I think dermoscopy will be very helpful.
So when you look at rashes with dermoscopy, it's a matter of looking all the time. So if you have a patient with psoriasis, look at the dermoscopy and you'll see that dermoscopy features are the same for all these patients, and the same with lichen planus, and the same with these various dermatitis. The morbilliform rashes are a little different because there really aren't many features to see other than perhaps some areas of red, as well as some dilated blood vessels. But inflammoscopy has become a new area. It's also good for infectious diseases, whether they be for scabies. It's easier to diagnose scabies with the dermatoscope than it is by doing a scraping in terms of sensitivities and specificities.
Thank you so much, Dr. Harrell. Any
Yeah.
other comments or questions?
Well, I just like to totally agree. I mean, I found dermoscopy so helpful for lichen planus. I mean, it just, lichen planus particularly is low-hanging fruit when it comes to that dermoscopy. I mean, it really helps you feel good about that's definitely the diagnosis without having to do a biopsy often. So I vote yes to keep using your dermatoscopes.
Okay, anyone else? Any final comments? Okay, can we have the last slide? So really, this was a real great way to start off the new year. We have not discussed rashes before, to my recollection, and Edwin, you did an excellent job on your case presentation, and so we thank Dr. Davis, and I know that Dr. Rabinovitz helped Edwina along. So we thank all of you, and we thank people who asked or answered questions. And so the next session will be February 3rd. So that's actually in 3 weeks, I guess. And Dr. Davis will be presenting on another rash. I don't know, do you know what rash you're going to cover next month?
It's going to be a surprise. But,
Okay. So Dr. Davis will present a surprise rash presentation. And the case presentation will be by one of our medical students, Mitchell Hansen, who has been involved in with Brenda in particular with a skin cancer prevention program. And the CME-CNE code is on the slide here, and you'll also receive, it should be in the chat, and you'll get an email with that code also. And just a reminder that you need to submit the code soon. Don't wait till next week, because that won't work. But you also have to be already, for new people, already registered with the MCG CME office. And if you have problems with that, contact us at the teledermatology email or Kenza Mamuni. So I think that is about it. Again, I am really thrilled to see so many of our healthcare providers from our the clinics around the state that have been participating in our original TeleDerm project. So it's really nice to see you folks again and staying with us. And feel free to let other people know about this program. It will generally be the first Monday of the month at 4 o'clock. And I wish everyone a happy and warm new year, which is not so far, but and I think we can close now. I ask the TeleDerm team members to stay on for a debriefing for a few minutes, and the rest of